Hi everyone, welcome back to our hashtag See Arthritis event at this year's Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting. This is the Arthritis broadcast booth where we have been interviewing up a storm over the and truly it is storming outside here in Quebec City. There's so much snow. Exactly, don't you think? It was a complete fluke, Dr. Lacaille. I'm so excited to be here with our partner, actually, empowering the Arthritis Broadcast Network, the Scientific Director of Arthritis Research Canada, Dr. Diane Lacaille. Thank you so much for coming in.
It's my pleasure.
We're trying to re-energize each other at the end of the meeting here, a long 3 days of great sharing of patient perspective, very important for this endeavor.
Yes.
But also sharing the learnings you've pulled together as colleagues from clinical research, even some basic research happening here in that knowledge translation, which is super important. Also, though, the presentation of yours in plenary, which I know our audience is going to love hearing about. So my job is to push go on you and have you share with us what you talked about during the plenary, Dr. Lacaille, and then I'll ask if maybe a couple of one or two follow-up questions on sort of current projects that you're involved in and leading.
All right.
So fire away. Tell us what you talked about during the plenary session and the importance of it to our audience.
All right. Well, the plenary presentation was about biosimilars, and biosimilars are biologic medications that are very similar to the original molecules that were developed for biologic medications and that become available once a patent has expired. And we say that they are similar rather than they are identical, simply because biologic medications by definitions are medications that are produced by cells. So,
which are alive,
exactly, and therefore it's not like a chemical synthesis process where you can make sure that you do the exact same chemical reaction and have exactly the same molecule. So they are similar, but they are not identical, and it's usually in the way the proteins are folded, for example. And in order for a biosimilar to be approved for its use, they need to show that the drug functions the same way as the original molecule and that it has a similar efficacy and that there's no signals of safety issue. And then they receive the same indications as the original molecule when it was first developed and went through extensive testing. So this is very reassuring, but because the testing that's necessary for regulatory approval is more limited than when you develop a new medication, which is why the biosimilar is available at a lower cost, can make people uncomfortable as to are they truly really the same when they're used in real life clinical practice on everybody without, on entire populations when patients are not selected to enter into a trial. So the purpose of our study was to use real-world data from the province of British Columbia, where we have data from administrative databases on everybody in BC, including medications on everyone. And we were able to compare what we call survival on treatment, which essentially is looking at the duration of time that people remain on treatment, assuming that if people remain on treatment, it means that the drug is working well for them.
And that it's safe.
So that there's no side effects and that it's working well. Otherwise, we would change the treatment. And so we compared the duration on treatment of when certain biosimilars for medications for etanercept and infliximab using a biosimilar and compared that to people prior to the policy change or before these biosimilars became available who used the equivalent originator. And the reason we could do this in British Columbia is that we had a policy at a very specific point in time where in order to get the medication covered under our medical plan and for it to be covered by the government, we had to use the less expensive biosimilar alternative. So this gave us a good context for what we call a natural experiment, where people are not selected, therefore there's no bias about, well, maybe this person's doing better, but it's not really the medication, it's something about the patient that made you choose them. So, and what we found, which was very, very reassuring for clinicians who prescribe these medications, and we also want to make sure we're doing, what's the best thing for patients, and also for patients who are being asked to use these biosimilar medication. We found that the survival on treatment, so the duration of time on treatment, was the same for the biosimilar as it was for the originator. And we also took into consideration things like, has the patients to whom we are prescribing the patients changed over time? Are there some of their characteristics at the time of starting that may be different? So we took that into consideration in our analyses to make sure that that was taken into account. And also, over time, our practice patterns changed. So, now we tolerate very little inflammation, and we have more alternatives. So maybe in more recent calendar years, people are stopping their medications sooner. So we also took that into consideration by comparing that with the survival on treatment of adalimumab, for which there was no biosimilar over the period of time we were studying, to make sure that the difference between the two was the same for the biosimilar and the originator, and for compared to the adalimumab after and before the policy change. So, just to say that this sounds like a very simple question, but it was quite a complex analysis to make sure that we took everything into consideration to make sure that there truly was no difference.
So for our audience, what your community, expert research community, calls it is rigor. So the science had a high degree of rigor.
Yes.
So meaning it was very good.
Yeah.
And then two, I just want to clarify for the audience, when you're using that term survivability, you don't mean live or die.
No.
You mean how long the person was able to continue.
Yes. Thank you for clarifying.
I go, ooh, survivability. What does that mean?
Yeah, treatment survival.
Just how long you would be on the treatment. So those are just technical researcher terms. No apology needed. That's why I'm here. I'm the lay translator. It's a fascinating study, and certainly the real world information you gathered in that experiment, in that real world experiment, very much mirrors in that much more highly controlled experimental environment. They mirror each other.
And that's important.
Oh, it's of utmost importance.
Yeah. Because, we can't just rely on one source of information.
Right.
In science, everything, truths that we believe are truths are based on being able to consistently find the same finding when you're looking at it from different ways in the trials, in the real world evidence, in Canada, in Europe. So it's not a waste to be repeating those things. Its consistency of findings gives us more confidence that that is closer to the truth.
That is one of the first pearls I learned from my research mentors in rheumatology was I kept looking at all these studies, flipping the page and like, why are they wasting all this money on the same question, on the same study? And it was explained to me, well, actually, we need to do them again, sometimes a number of times, to ensure the results are the same. And I said, but why? Because when we give advice in our clinics, we need to make sure that this advice is applicable across this broad spectrum of patient population. Yeah. And I went, aha, of course.
Yeah.
Smart.
Yeah.
So that it really, the information you're giving us, the prescriptions you're giving us of advice, of things to follow, not just our medication plan, but other things also, because this same principle applies to our exercise research, to, social science experiments of that type. You have to have replication.
Yeah,
to
definitely.
make sure that the
it's
advice
a true
is
finding.
applicable.
It's not a chance finding; it's a true finding.
So, just a side of patient participation and research learning there for you. Arthritis Research Canada actually has been historically and continues to be a real leader in involving patients in all aspects of the research. from budgeting, where the rubber really hits the road. Where do we, carve out the budget for projects? What are the priority areas? To being on the board of directors, to having its own advisory board filled with patients who are expert.
Oh, we are very fortunate. We are very thankful for our Arthritis Patient Advisory Board. They give us invaluable advice, and their expertise is the lived experience with the disease, and their voice really matters, and they really change how we look at some of our research ideas and how we go about with our projects, and they also help us get the word out.
Exactly. So from
many roles,
from formulating the question, to discussing with you what's the best way of gathering the information, the methodology, to assessing the results that you've collected from all those who've participated, to then thinking, well, what's the important results here?
What does that mean?
What does it mean to me? Well done. I like that. That was not practiced, by the way. That's super, super exciting. So congratulations on that presentation. To our audience, it's a big deal to be chosen for plenary as a plenary speaker at this meeting, which only happens once a year. The other question I wanted to ask you before you run off to the poster session, which I know is ongoing, and you've got a number of trainees who are presenting data there, is because I'm working with you on this project. There's a project called FlexCare, and it's just starting. Tell us who is supporting it, which is really important that we recognize those who are supporting it. And what the project is aimed to do. Because I think it's exciting.
I am very excited about this. We've been working on this project, been writing a few grants, which is how we get funding to do our research, for about a year and a half now. And so we have some funding from the CIHR for stakeholder engagement, and we have funding from the Arthritis Society for the operating funds for the project. And this is FlexCare. So it's a new way of delivering care that we want to co-design with people living with arthritis, so the people who will be involved in receiving the care, as well as with healthcare professionals, the one giving the care, and also health policymakers and people involved in administration. So getting everybody together to really rethink how we give care, how we provide care, The pandemic has really changed how care is delivered. We've all experienced virtual care, different forms of virtual care. We need to think about how do we incorporate this into care moving forward. That's one aspect. The other aspect is there's incredible technology that's now available to us that we are not leveraging when we are continuing to do care our traditional way of having patients come in for a 20-minute appointment at fixed interval in time, because I see you and I try to guess, are you going to need to see me again in 3 months or in 4 months or in 6 months? And then in between, I don't see you, and you have to manage your disease in between. Sometimes if things really don't go well, you will contact me, but you're hesitant, you don't want to bother me, and so it's not ideal. But we have technology to be able to monitor symptoms in between appointments, and my vision of this is that we could let the monitoring of the symptoms in between and specific characteristics of each patient and what matters to them, their preference, some of their characteristics of their disease, actually guide how we provide care. So we talk about precision medicine, which is personalizing the choice of treatment. I'm talking about personalizing care, taking that concept and bringing it to the health services, to the care delivery
to
model.
The entire sphere.
Exactly.
That should
to the
be
whole
healthcare.
System. Exactly. So it's not. So it's personalizing what type of healthcare encounter do you need, and when do you need it? How should this care be delivered, and by whom, based on the remote monitoring of your symptoms, so we can see how your disease or your symptoms are changing, based on your preference, based on Do you belong to a group who is at a greater risk of health inequity? Do you have a lower health literacy that maybe I need to see you? Maybe for you, if you don't have a good literacy with using computerized equipment, then maybe virtual care is not good for you. Maybe I should be seeing you in person. So it's really trying to personalize how we provide the care, and rather than having something that's fixed, doing it, evolving and being responsive to the needs.
Yeah.
And that way, rather than having things at fixed times, we can better respond to the needs as they change over time. It's not just that they change from one person to the other, but this disease, we know there's flare-ups. And if all my appointments are booked up with these fixed appointments, there's no room left for when you actually really, really need me.
Yeah, I mean, it's a cookie-cutter approach.
Yes.
Versus one that forms around you.
Yes.
Forms around your own needs.
I love that way of putting it.
There you go. There
so
you go.
So this is like what I've described as a vision.
Yeah.
But, to put this, first of all, we want to see how this vision resonates with people living with the disease. In order for this to work, to really meet people's needs, we need to get people's perspectives as to what is important to you for this system to work well for you. So we need to really gather the input of patients and of professionals and of the people who are involved in the administration of care as well, to really co-design this thoughtfully, make sure that we design it in a way that we don't create more health inequities. Mm-hmm. That's another really important concern. So we're going to be working with people who are at greater risk of health inequity because of their social determinants of health, their
cultural background, beliefs.
Their beliefs, their rural and remote community, different people who've recently arrived to Canada who maybe are not as comfortable in the healthcare system. Indigenous people who have sadly faced a lot of racism in healthcare.
And still do.
Yeah. So making sure, how do we design a system that works for everybody?
Right.
So we're kind of in the designing stage right now, and then we'll be testing it.
And you test it because you need to be sure
that it works,
that the new vision is workable for people. So just in the same way you did this experiment around biosimilars, and to actually check, and then recheck, and then check again, you have to do the same thing with the healthcare system.
Yeah.
Right?
Yeah.
Or a model, as one would call this.
Yeah.
So super important to make sure that we know that when you launch this new thing, that it's actually the right thing to do.
Yes.
Yeah.
And you need to test along the way at all the levels, and never assume anything. So I'm not going to assume certain beliefs of patients. I'm going to check in and get that input.
Yeah.
Then you create a little bit of it, you test it. Then you create another little bit of it and you test it. And you have to test all along the way.
Yeah. It's amazing. I think a number of
I may not be able to retire.
Ever. Well, we're not going to let you. Here's the big surprise. It's that
I'll pass it on to the younger generation who are actually doing amazing work. And
we have a great young community too in rheumatology across disciplines, right?
Yes.
Not just in rheumatology, but in the arthritis health.
So they will finish that work.
They will finish that work.
I'll start it and they'll finish it.
I can kind of feel our audience members high-fiving on this project because those of us who live with a type of disease where we require regular rheumatology care, Dr. Lacaille, it is often the case when we scratch our heads and go, why is it being done this way?
Yeah, totally.
Right?
And
why am I going now when I just saw that person and I don't really need to go back this month? Why don't I just wait and tell them when I need to go in?
Yeah.
And why do I have to be re-referred? It's like being put, a man on the moon and you get out on that tether and you're way out in the atmosphere and then somebody cuts it. No, somebody cuts it and you have to get a re-referral to go back.
Yeah.
You know what I mean? Like,
The system is not patient friendly.
No. Just view us as sometimes floating away from the mothership.
Never thought about that. I'm not going to forget that image. I like it.
I'm the queen of metaphors. I've got one for everything. Listen, we obviously wish you the best of luck.
Thank you.
A speedy luck, by the way. We want this done tomorrow.
Yeah, exactly.
Not going to happen tomorrow, folks, but definitely.
And thank you for your involvement.
It is my pleasure. I don't think in all the years I've been involved in research, either as a participant or a patient leader, as a project contributor, I don't think I've ever been more excited than I've been about this project. You're hearing that for the first time.
That's right.
And I'm not sucking up to you trying to get you into the booth. I'm telling you this during the interview. Wow. Anita, do we have any questions for Dr. Lacaille before we let her scoot off?
Do you have any tips on how researchers can make research more equitable, diverse, and inclusive?
That's her.
That's
near in her heart.
Yeah, that's very close to my heart. Yeah. That is a very, very good question, and something that we're definitely struggling with because there's very clear evidence showing that research, that people who participate in the research, who are included in the studies, I should say, do not represent the diversity of the patients that we treat. So it's we have to figure out how to do this better. There's lots of talk about it. There's lots of workshops. But I don't think we've yet quite figured out, other than applying the same principles of equity, diversity, inclusion that we are discussing in other spheres. So essentially, if we want if we want patients from a diversity of backgrounds to participate in our research, we have to create a safe space. So we have to create a place that they will be comfortable.
Which means diversity on the research team.
Totally.
As a very strong starting point.
That's very important.
Yeah.
And we also need to put special effort into recruiting participants everywhere where the participants are. So, because we just put out an ad in one place and then get all the people from the dominant culture that come, then, we're not being representative. So we have to think, well, who's not at the table, and where are they, and why are they not at the table, and go to where they are, remove the barriers for people to be able to participate. And so we're inviting them in, and once we invite them in, we have to create a safe environment so that they stay in and that they play a meaningful role. Yeah. So that's kind of, it's a bit of an approach if you want, but I think that's probably my sort of quick answer to this. But we have so far to go because we're not doing that well. But I have hope. I think we're becoming more mindful. We're learning about it. We're discussing it. We're reporting on it. It's being asked of us, which is really good. Now, when we write a grant, we're asked, how did you consider diversity, equity, and inclusion, and what effort will you put in making sure that you recruit
the results and
that the results are applicable? Yeah. And we now have to report for different subgroups as well, whether it's gender, whether it's race, whether it's socioeconomic status, etc.
Yeah.
And so I think we're moving the needle in the right direction. We still have a lot of work to do, but hopefully we're getting there.
Yeah, we also have a number of resources, and these are going to be very specific to Indigenous peoples across the land. There is truth and reconciliation, and with that comes reconciliation. And we have to remind ourselves that research done today is done in colonial structures.
Yeah.
They've been handed down over, 140 plus years. And at the individual level, we have to unlearn our colonial ways and practices. Mm-hmm. So we have an individual responsibility to addressing equity, diversity, and inclusion. Mm-hmm. It starts with the N of one, that's us. We have a bunch of resources that are available on Arthritis at Home, things we've done with you, things we've done with other researchers at Arthritis Research Canada, things we've done with our Indigenous scholar and mentor, Dr. Terry Lynn Fox. There are so many resources out there that will help you get on the learning journey and the unlearning journey as the starting point.
Yeah.
It's not performative. You don't just say, oh, I recruited here, I did this, I had a meeting with that.
It's not ticking a tick box.
It's not ticking a box. In other words, it's not performative.
It's transformative. It's changing everything about
it's human.
Yeah.
It's taking research out of the realm of tick boxes and putting it into human experience.
Yeah.
And into love, into research as ceremony is the best way of putting it. Dr. Fox. I learned from Dr. Fox. Research as ceremony. And every culture, every race, every group of people have their own ceremonies.
Yeah, yeah.
And those have to be reflected in the research to be real for the participant. And only then do you engender trust, harmony, belief, desire to participate, all of those wonderful things. So,
and trust cannot
underscore that enough.
Cannot underscore enough trust.
Yeah, and we've lost trust with folks in the BIPOC community, with the LGBT community, because we've operated in non-ceremony-based systems and structures. So our promise, our commitment is to work every day to deconstruct those and to rebuild them with those very people to do better at what we do. And I say that from a lay education, grassroots organization perspective. I know you say it from a research perspective.
Yeah, and we're also very committed to that at Arthritis Research Canada.
I know you
at
are.
Arthritis Research Canada as well.
Yeah.
And I've worked a lot with Indigenous communities in developing services with the community that the community identifies as meaningful to them, to provide arthritis services that are rooted in Indigenous ways of knowing and in Indigenous approaches to health.
Yeah, absolutely.
So I think, the other thing is the community-based approach of these projects that I think is really essential.
Yeah. So that's a double-barreled, long-winded answer to the question.
We kind of drifted
away.
away
We sort of drifted, but this is what happens when Dr. Lacaille and I get together. Any other questions? No? Okay, great. We'll be posting resources available to you to go learn more about this topic. You can check arthritisresearch.ca to learn about current research, including FlexCare, that's just really getting its wind in its sails, but also the results from completed projects since your 22 years of research existence, and going strong with centers in Vancouver, Calgary, Laval, and now Halifax. We can't thank you enough for fearlessly leading Arthritis Research Canada, Dr. Lacaille. We appreciate very much you coming in. We can't wait to see you back home in Vancouver, which is where we both live, on the beautiful land of the Coast Salish peoples. So we thank you for joining us, and we welcome you back very shortly.